May I first invite the chairperson and co-chairperson on stage, Dr. Maitri Das and Dr. Arindam Dev. Welcome, ma'am. Do we have Dr. Arindam Dev here? He's not here, okay. And I see Dr. Sumit Grover is not here as well. Okay.
Good afternoon, everyone. Myself, Gargi Deshmukh. I'm postgraduate resident in Amrita Hospital. I'm presenting a case, the straw that broke a camel's back. It's not moving. No, nahi kar raha. So it's a 50-year-old lady presented with a decrease in vision in left eye 2 weeks back. Her best corrected visual acuity was 6.6 in right and 6.9 in the left eye. Her anterior segment examination was normal. There were no cells and flares, and intraocular pressure was normal. So this is a fundus, right eye showing 2 subretinal orangish lesion, temporal, superotemporal and inferotemporal to the fovea, and left eye showing large subretinal creamish yellowish lesion, temporal to the disc, and there is a subretinal dark lesion which can be subretinal hemorrhage or RP atrophy. So moving to the OCT, right eye showed RP irregularity and RP thickening and slight elevation of the RP. Left eye showed subretinal creamy yellowish region through which we can see PED. On fundus fluorescence angiography, there is a stipple appearance in the stipple hyperfluorescence in the right eye. Left eye showed stipple hyperfluorescence and window defect in the left eye. So we came to the differential diagnosis of CNVM, intraocular lymphoma and metastasis. ICG was done to rule out polyp. There was no evidence of polyp. So we gave, as patient was not willing for biopsy, we gave 1 injection of anti-VEGF in the left eye, which was bevacizumab. After which we followed up, and at 2 months of follow-up, she was having significant improvement was vision in the left eye, which was 6.6. So we did further investigation. Ultrasound abdomen was normal, PET CT was normal, chest X-ray was normal, and blood test for rule out other infections was normal. So 1 month after that, she came with a decrease in vision in right eye. Her vision in the right eye was 6.18, and she had fine KPs and 1+ cells and minimal vitritis in the left eye. And as we can see, there is a significant increase in subretinal creamish yellowish lesion in the right eye. So this is the picture showing increase in the subretinal creamish yellowish lesions in the right eye. And left eye also, as we can see, there is a creamish yellowish lesion inferior to the arcade. So we did OCT. OCT in the right eye showed RP thickening with sub-RP material, and left eye also showed RP thickening. B-scan showed multifocal choroidal elevations, and we reached to the clinical diagnosis of primary vitreoretinal lymphoma. To rule out CNS involvement, we did MRI brain, and we also did CSF studies, which was normal. Further, after that, we did vitrectomy with subretinal fluid biopsy, and intravitreal methotrexate was given, and silicone oil was injected. So this is a picture showing 1 week follow-up. As we can see, there is a decrease in subretinal lesions. So pathology showed of the vitreous sample did not show any malignant cells, but subretinal fluid cytology showed atypical cells, high NC ratio, coarse chromatin, and it was positive for LCA, CD20 and PAX5, and negative for CD3, and Ki67 index was more than 80%, suggestive of malignancy. So this is a picture of pre-op and post-op 1 week. As we can, she has a improvement in the vision 6.9. So coming to the plan, if there is a 1 eye involvement, we do vitrectomy and we treat intraocular methotrexate or rituximab. If there is a bilateral involvement or brain involvement, we have to treat it with the chemotherapy and radiotherapy and systemic therapy. So this is a meta-analysis showing 19% patients who come with the intraocular lymphoma already have CNS involvement, and 58% will have CNS involvement over the course of time. So our patient received systemic chemotherapy and intravitreal chemotherapy. So highlights of my case are that if there is absence of AC cells or vitreous cells, negated the possibility of the inflammatory causes. Rapidity with which lesion showed in second eye showed it to be malignant process than neovascular process. And this is actually the first case of primary intraocular lymphoma in which intravitreal bevacizumab alone was shown the significant resolution. So intravitreal bevacizumab treatment for the intraocular lymphoma should be studied for further. Thank you.
Thank you, Dr. Gargi. You've wound up well in time. Do we have any questions? Thank you. I think that was a great presentation. Thanks a lot.
Thank you so much.
Is Dr. Arvind's presentation ready? Or can we call the next speaker? Ready? Okay. Do we have Dr. Anjani Agarwala here? Dr. Anjani is here? No? Dr. Jagruti?
Vishal Prakash Nandi is present. Vishal next to speak.
Vishal Prakash is there? Okay. And what about Dr. Kalpana? Okay, both are there. So I think we'll go with Dr. Kalpana next and then Dr. Vishal.
वॉइस कहाँ हाँ है
रात में ट्रेन है मेरी संडे मेरा दोपहर में है कितने बजे का सर मेरा भी 2 कल है सर सेशन 8:30 से स्टार्ट है हाँ तो मैं रहूँगी सर उसमें 4 बजे से होगा हमको मुझे लग रहा है 4 बजे नहीं 12 बजे से क्या 12:30 हाँ मेरा सेशन हो जाएगा उसके बाद होगा संडे को ही है हाँ
तब तो आ रही थी
मेरा कीनोट एड्रेस होगा ठीक है सर फिर बहुत अच्छा रहेगा हाँ हाँ
Why things are not ready means it's a problem in every hall.
Dr. Kalpana Bandwal, please go through your slide. Everything is okay? Okay.
Present the PPT.
Dr. Arvind, can we ask the next speaker? Okay. Dr. Kalpana, can we have your talk, please?
Yes, ma'am.
क्या हुआ है?
Good afternoon, everyone. Today I am going to do a case presentation on endogenous panophthalmitis in a chronic kidney disease patient. I do not have any financial interest. A 47-year-old male, known case of chronic kidney disease since past 7 years, was on hemodialysis for last 1 month through the tunneled central venous catheter in the right internal jugular vein. The patient presented to our outpatient department with a complaint of sudden painful diminution of vision of right eye since past 2 days. Coming to the history of presenting illness, the patient was apparently normal 2 days back when he started developing sudden painful diminution in right eye associated with redness, purulent discharge and swelling of the lids. History of fever following the last session of hemodialysis 2 days ago was also present. There was no history of trauma and recent ocular surgery. Coming to the visual acuity, in the right eye, the visual acuity was PL positive, and in the left eye, the BCVA was 6/9 and N6 with spectacle correction. On anterior segment evaluation, in the right eye, the lids were edematous and the IPF was narrow. The conjunctiva showed congestion and chemosis. The cornea was edematous and hazy with fresh keratotic precipitates lining the corneal endothelium. In the AC, a flare of grade 4 was present with hypopyon lining in the inferiorly. And the pupil was mid-dilated, round, regular and sagitally reacting to the light. Coming to the left eye, the anterior segment was within normal limit. On posterior segment evaluation, the right eye showed vitreous flare of grade 4 with rest details not visible, and in left eye, the fundus was within normal limit. Coming to the general examination, the patient was thin built and poorly nourished and afebrile at the time of presentation. Pedal edema and swollen hands were present, and the blood pressure was 170 by 90 millimeter mercury with rest vitals within normal limit. Coming to the blood investigation, there was raised WBC with a neutrophilia of 83.5%. The patient was anemic with a hemoglobin of 5.3 gram per deciliter, and the serum urea and creatinine, an inflammatory marker, that is procalcitonin, was raised. On blood culture, Klebsiella species was found positive, and it was sensitive to antibiotics such as amikacin, ceftazidime, gentamicin, imipenem, ofloxacin, and piperacillin and tazobactam. On doing the aqueous swab and urine culture, no growth was found. Coming to the MRI of the orbit, in the right eye, features of endophthalmitis and panophthalmitis spectrum with breach in the sclera and orbital cellulitis was seen. Here in the MRI, we can see that there is heterogeneous signals in the vitreous along with the inflammatory thickening of the extraocular muscles and the preseptal tissue. And there is also deformed structure of the right lobe. Coming to the diagnosis, it is a case of endogenous panophthalmitis secondary to the IGV catheter infection. Coming to the treatment, the patient was started empirically on the intravenous antibiotics along with topical steroids, antibiotics, cycloplegics, and intraocular pressure lowering agents. One dose of intravitreal injection of antibiotic comprising of vancomycin and ceftazidime was also given. However, the condition of the patient deteriorated. As we can see, here is the formation of a scleral abscess, and due to the presence of the scleral breach and orbital cellulitis, the patient was further planned for evisceration with frill excision of sclera of right eye. On follow-up, the other eye was quiet. Coming to my conclusion, the early diagnosis and management in these cases is very important. However, the outcome may be poor in most of the cases requiring evisceration and enucleation. The factors for the better prognosis depends upon the initial visual acuity, the early first visit of the patient, the virulence of the organism, and associated systemic factors, which in this case is the poor renal status of the patient. These are my references. Thank you.
Thank you, Dr. Kalpana. Do we have any questions?
Dr. Kalpana, any case reporting regarding the CKD patients, how many patients and what age group?
Sorry, ma'am?
What is the age group criteria, that type of CKD patients having a panophthalmitis? Yeah, this is not reportedly so current, na? How many cases you have seen? I am asking about the case report. CKD patients.
CKD patient, ma'am, I've seen numerous, but with the history of endogenous endophthalmitis or panophthalmitis is the only one case I have I've seen. Yes, ma'am. I've not seen any other cases like this.
And what the age group of that patient?
Ma'am, this is 47-year-old ma'am patient.
47
yes,
years
ma'am.
old.
And
The
he's a known
patient
case of CKD since 7 years, and he was receiving hemodialysis for the past 1 month currently.
This is a very rare, whenever I've also multi-specialty and having a CKD patient, always the dialysis was going on. But last 3 years, I have not seen that of the patients, very rare. But the most of thing, the immunity power is very much less that type of patients.
Yeah.
Okay. And patient having so much dialysis patients, so they have a hepatitis B positive, some have HIV B positive. That means the total plus point is the patient immunity is very much low. That patient very attentive, that type of patients, and physician consultations, and always you look after every patient which go through the hemodialysis, always you concentrate on that patient. Okay. So that
Was he on any immunosuppressive? No.
No, ma'am, he was not on any immunosuppressive.
Okay, because the glucose level is little bit normal, 5.8 now. Glycosylated
ma'am.
hemoglobin
It was
5.8.
pre-diabetic range, ma'am.
That means the patient having not a diabetic
No, ma'am, he was not a diabetic. ma'am.
criteria.
But he
Okay,
was
thank you.
anemic, ma'am. The
Anemic.
hemoglobin was low, ma'am.
Every patient is anemic,
Yes, ma'am.
I think. Okay. Yeah. Thank you.
Thank you, ma'am.
Nice presentation.
Good afternoon, everyone. Myself, Dr. Vishal Prakash Nandeshwar, presenting the topic thermal burn of ocular surface due to accidental vapor explosion in iron slag yard of steel plant. Introduction: accidental burn due to failure in safety or malfunction of process is very devastating. It results in loss of vision and great impact on the socio-economy of workers and employer. Ocular burn due to steam vapor explosion in hot iron metal slag due to water entrapment is rare and alarming. The iron slag yard in steel plant consists of 3 phases: skimming, cooling, and Loading, each phase sequentially progress for 8 hours. In skimming process, slag is poured in yard with no excess water, resulting in fewer explosion risks. Then an unstable and dangerous procedure, workers operated nozzles manually for the first water injection cooling. A significant point to be noted is that workers poured water by using the bar type water injection, allowing cooling water to flow directly into the high temperature molten slag that ultimately caused vapor explosion to occur due to expansion of fluid volume. Case description: my patient was 24-year-old Hindu male contractual worker. He got burned due to steam vapor explosion at iron slag during cooling process. No protective device was used. This is the external photo of the photo showing facial and ocular burn. We can see that periocular scald burn, corneal burn in bilateral eye due to vapor explosion in iron slag. Ocular findings in right eye: visual acuity was counting finger at 2 meter. Periocular skin scald burn present. 3/4 of the corneal burn with a 270-degree limbal ischemia. In left eye, visual acuity was 6/60. Periocular skin and scald burn. Inferotemporal corneal burn with a no limbal ischemia. On fluorescein staining of cornea showing epithelial defect in right eye, there was large epithelial defect, and in left eye, relatively small epithelial defect was present. On investigation, routine blood investigations were within normal limits. On X-ray and CT scan of both orbit reveals no foreign body and no fracture of bone. On treatment part, medical management, we give antibiotics, steroid drops, lubricants, cycloplegics, and vitamin C tablets. In surgical part, amniotic membrane graft, tenons patch graft, and tarsorrhapy was done. This is post-op photo of the patient. Amniotic membrane graft with tarsorrhapy and tenons patch graft was done in right eye, and in left eye, tenons patch graft was done. After healing, we can see in right eye and in both eyes, the cornea was clear, epithelial defect get healed, and anterior chamber was quiet. My conclusion was that corneal and limbal involvement prognosticate the outcome. Early amniotic membrane graft and tenons patch graft helps for early visual recovery. To ensure use of protective safety device by workers, regular preventive maintenance of machine to prevent breakdown. These are my references. Thank you.
Do we have any questions?
What was the visual recovery?
Visual recovery means 6/60. Right eye 6/60. Left eye initially 660. It improves.
When the patient has come after the injury,
After 1 month, ma'am.
the time duration of the patient,
Yes, ma'am?
1 month after the injury he came.
No. After
the time duration when the patient come to you,
2 days, ma'am.
2 days.
2 days during Diwali
And
vacation.
steroidal dose is there? How
Yes,
much
ma'am.
the steroidal dose is there?
Yes, ma'am.
Steroid dose, eye drop, steroid eye drop.
Steroid eye drop was given.
How? What is the dose?
1 drop 8 times we have given, ma'am.
1 drop.
8 times.
Why the patient came 2 days after the injury?
Ma'am, maybe actually that time Diwali vacation was going on.
The time duration is little bit very long. 2 days is very much.
And
the patient.
he was far away from the hospital.
Also in the Bokaro, also there is a electrostaticity. So many
Actually,
patients has come with a thermal burn.
This explosion occurs in Jharsuguda plant.
Yeah, Raurkela is
and
the
we
part
are
of.
at Raurkela IGH.
Yeah, that is the part of still city, I think. Raurkela. The time duration is very much important, that type of patients. If the patient has come to you 24 hours, 72 hours, you are very conscious about the steroidal use. Very conscious. Sometimes your estimate that the patient have a steroidal, they will recover and they will not recover, depends on your patients
Yes, ma'am.
and what type of presentation is there. Okay. So, steroid in every book and in a practical view also, steroid dose is, if you want to give or not give, decide yourself. But the 2 days is, I think, that is the 48 hours, na?
I think it's very sad that even in today's day and date, so many patients don't have access to basic
Your
ophthalmic care.
limbal ischemia is also there.
Yeah.
Limbal ischemia.
And I think
Ischemia is also
probably we need to sensitize general physicians towards being more aggressive about their referrals to an ophthalmologist, because
Yes, ma'am.
I'm sure we have enough connectivity to make sure a patient can reach an ophthalmologist in 24
Yeah,
hours.
strong antibiotic with the ketorolac and everything is a very safe side. I think so many cases I have seen I'm in a Bokaro Steel City, and the patient has Electro Steel City, Electro Vedanta is there, the thermal mud injury is so much cases I have seen that. So time duration is always reported. It's a very must. And if you have seen the limbal ischemia, then you have a alarming sign, you know. So I think you are more conscious about the steroid use. You just switch over the more antibiotic, more stronger antibiotic is there. And also IV is also, you have just put it. Any others sub-additive skin infection is there, you just put it.
Yes. Thank,
Thank you,
Because
Dr.
this is
Vishal.
my part of practice, I don't know.
thank you.
Thank you, Dr. Vishal. I think last but not the least, we have Dr. Arvind Kumar, who has really put in a lot of effort to make sure
Sorry for
this
everything.
presentation has happened.
Just play it.
Greetings everyone. Thank you Scientific Committee for giving me the opportunity. I am presenting a case of simple limbal epithelial transplant in a case of alkali burn in an 11-year child complained of sudden onset, gradually progressive, painful decrease of vision in left eye associated with watering, redness and photophobia following Lyme injury. On examination, his visual acuity was reduced to finger counting at 3 meters with 360-degree limbal ischemia, total macular haze with no appreciable anterior chamber details. For successful SLAT surgery, preoperatively evaluation of donor cornea from the superior limbus is a must, along with evaluation of recipient cornea, which needs to be wet with no adnexal pathology, and proper assessment of corneal scarring and thickness is mandatory. Topical phenylephrine drops can be instilled to avoid any hemorrhage under the graft. Under GA, from the other healthy eye, conjunctival limbal autograft surgery was started after properly placing the universal eye speculum and passing of superior rectus bridal suture for proper exposure. Then the conjunctival flap was created just behind the superior limbus, around 2 to 3 mm away from the limbus, and limbal conjunctival tissue was evaluation of donor cornea and thickness is mandatory. Conjunctival limbal autografting the universal eye speculum. Then the conjunctival flap was created just behind the superior limbus, around 2 to 3 mm flap was created just behind the superior limbus, around 2 to 3 mm away from the limbus, and limbal
इसमें फॉरवर्ड कर देता हूँ अभी तो दूसरे हॉल में रन कर रीस्टार्ट कर लीजिए
Greetings everyone. Thank you Scientific Committee for giving me the opportunity. I am presenting a case of simple limbal epithelial transplant in a case of alkali burn in an 11-year child complained of sudden onset, gradually progressive, painful decrease of vision in left eye associated with watering, redness and photophobia following Lyme injury.
Doctor, do you
On
have
examination,
PowerPoint?
his visual acuity was reduced to finger counting at 3 meters with 360-degree limbal ischemia, total macular haze with no appreciable anterior chamber details. For successful SLAT surgery, preoperatively evaluation of donor cornea from the superior limbus is a must, along with evaluation of recipient cornea, which needs to be wet with no adnexal pathology, and proper assessment of corneal scarring and thickness is mandatory. Topical phenylephrine drops can be instilled to avoid any hemorrhage under the graft. Under GA, from the other healthy eye, conjunctival limbal autograft surgery was started after properly placing the universalized speculum and passing of superior rectus bridal suture for proper exposure. Then the conjunctival flap was created just behind the superior limbus, around 2 to 3 mm away from the limbus, and limbal conjunctival tissue was
It's got still. चलो ठीक है. Thank you. So the other eye. वीडियो तो नहीं चल रहा ना. So in the other unhealthy eye, as you have seen the picture, so minimal this epithelia after the 360-degree conjunctival peritomy, this epithelia along with superficial stroma, it was removed, and then freshly prepared amniotic membrane graft. I always prefer freshly prepared from an uncomplicated lower segment caesarean section, and then the amniotic membrane was placed over that cornea, and with the basement side up, and then this tissue with the help of this fibrin glue, it was divided into 8 to 10 pieces. Close it. So when we are putting that the harvested part from the healthy eye, so the epithelia and the pigmented part, the smooth part, it needs to be on the superior side, and the fibrous stromal side, it needs to be on the inferior side, and it needs to be placed in the mid periphery area, avoiding the pupillary or the visual axis. And then with the help of fibrin glue, again it was placed, and then followed by the placement of the bandage contact lens, and that was removed after a week. And steroids and lubricants, they were given in ample amount, and the patient's vision from finger counting 3 meters, it improved to 6/24. So it's a very cost-effective technique as we compared it with the cultivated limbal epithelial transplant. So it cost around 5 lakh, whereas this technique hardly is 3.5 thousand to 5,000 only. And very good result. In CLAT, the healing starts from the periphery. So visual axis is the last part. And the especially in the kids, the success rate of CLAT is very low, only 44%. As per the literature, whereas in the simple limbal epithelial transplant, it's very high, 77%. So we have done a series of 22 patients, so they have a working vision from 6/36 to 6/18. Thank you so very much for your patient listening. Thank you.
Thank you, Dr. Arvind. Do we have any questions? Thank you.
Thank you.
So I think we can wind up this session because the other two speakers are not here. Dr. Anjani and Dr. Jagruti are not here.
Just come and photo.
Nothing on this list. I think that's the next session probably. This session we finished. I invite the speakers for a session photo.